My contribution today will be talking about some waveforms. There are a lot of domains in the waveform, so I'll be skipping few of them, but I will try to just give an idea that few of the things that you usually neglect, I'll be talking about those things primarily in the exam. So we'll be talking primarily about capnography, arterial waveform, pulmonary artery catheter waveform, central venous pressure, IABP, intracranial pressure waveform, and I'll be giving you some framework for the ventilation waveform, but I'll not go in detail into the ventilation waveform because itself it is a very uh, big portion to cover, but I'll give you some framework to what is required and how do you approach it. Well, first of all, capnography. I know you all are master in capnography, and in the exam, you may or may not get one of these, but these are the things that you think that you are very confident of, and then start struggling when questions were asked. Um, so, capnography is a measurement of partial pressure of carbon dioxide in the exhaled breath, that we know, and it is plotted against time. And there are two types of capnometer that you know already, so I'll not go in detail about it. What they ask in the exam is the waveform difference and how do you predict a capnography waveform or how do you predict a pathology based on capnography waveform. First of all, the capnography as such provides instantaneous information about effectiveness of ventilation, perfusion, and metabolism. And in clinical practice, we use capnography to make sure that the ETT position is well in trachea, that is endotracheal tube position. It also helps to delineate the effectiveness of CPR. If you are getting some number of capnography, take a number 15, 20, etc. That gives you a effectiveness of CPR that is ongoing. It also represents a spontaneous recovery or spontaneous return of circulation. If there is ongoing chest compression, you will see your capnography waveform will come if there is spontaneous return of circulation. So in clinical context, these are the three major uses of capnography. Now, sometimes the examiner are very fond of asking about the parts of a capnograph. What are the parts and what do they represent? So universal nomenclature for the capnograph is it has four phases, and the phase starts with 1, ends with 0. So 1, 2, 3, and 4, as you can see, and there are different points that is marked in this graph. So A, B, C, D, and E. So the wave that goes from A to B represents the dead space ventilation. B to C represents the ascending expiratory phase when the patient or individual is expiring, so that gradually the CO2 concentration is increasing. C to D phase is called as the alveolar plateau, where there is a small escalating increase of CO2 concentration. And D is the end tidal carbon dioxide. That's what we measure or that's what we see in the monitor. And then it is followed by the descending inspiratory phase where the CO2 gradually comes to zero. Okay, so this is the phases of the capnograph. Now, if you go in a schematic manner, that's how it looks like. So phase 0, phase 1 represents the anatomical dead space. Phase 2 represents the expiration where there is increase. Phase 3 represents the alveolar ventilation, and then you come back to phase 0 again. Now, the interesting thing is that not all the component are cut off by their form. Like this straight line is again divided. This straight line is again divided. Only the alveolar ventilation, which is the phase 3, which is a continuous phase. Okay. Now, there are different angles that can be asked in the exam. One is called as the alpha angle, which is a angle between the phase 2 and phase 3. And there is a beta angle, which is an angle between phase 3 and phase 0. We'll talk about that angle in a minute. But before that, again emphasizing that phase 1 represents the dead space ventilation. So sometimes they will be asking about what do you mean by dead space and what are the types of dead space. So this is a fundamental question that you need to know from the physiology. So something called as an anatomical dead space and something called as a physiological dead space. So the physiological dead space is a combination of anatomical and alveolar dead space. So alveolar plus anatomical dead space makes the physiological dead space. So the anatomical dead space is the dead space where there is no gas exchange in the conducting airway. The alveolar dead space is from the conducting airway till the alveolus where there is gas exchange happening. That part is for the alveolar dead space. And if you combine both of that, that accounts to your physiological dead space. Usually, in a healthy adult like you and me, the anatomical dead space is equal to or almost equal to the physiological dead space. You don't have a alveolar dead space that much of a bound. Okay, but as pathology or as physiological changes happen in the body, as somebody becomes pregnant, obese, or with age, in that case gradually the alveolar dead space creep in, right? In that case, that's why the total dead space, which is the anatomical and the alveolar, there is a value to the alveolar dead space in later part of the life. Initially, in a healthy young adult, the alveolar dead space is not that much. Okay, they can ask you about what are the types of dead space. Now, as we are discussing earlier, phase 1 is a dead space ventilation. This is the beginning of the exhalation where the dead space is cleared from the upper airway. Phase 2 is the expiratory upstroke, this one, which represents a rising CO2 concentration as it reaches from 0 to a peak level. Phase 3 is the alveolar plateau, which is exactly not a plateau but a slightly inclined or escalating line there, and phase 0 again coming back to the inspiration. Now the angle that we talk about is the alpha angle and the beta angle. Now the beta angle, first of all, the alpha angle is the indirect indicator of VQ mismatch of the lung. If the alpha angle is more, then it represents a more significant VQ mismatch. If the alpha angle is nearer to normal, that means there is no VQ mismatch or within physiological limit. The beta angle is the angle between phase 3 or the alveolar plateau and the inspiratory phase, this angle. If there is rebreathing, then this baseline comes up, the baseline comes up and this angle becomes wide. So if you have a wider beta angle with the baseline coming up, that means there is rebreathing. Okay, so these are the two important questions they can be asking about alpha angle and beta angle. Now going to pathology, so these are the 12 or 15 images that are there which can be asked in the exam as a slide to identify the pathology. So I would let's see who wants to answer or how many can you get correctly. Anybody, any taker for the first one, the A, graph A? Even you can write your answers there. I'll wait for the first 5 and then we'll go across quickly. Okay, lots of things coming up. COPD, bronchospasm, sarc finning. All right, let's see. Bronchospasm or airway obstruction. Okay. What about 2? What about B? What's happening with B? Curaric left, CO2 rebreathing. Rebreathing. Okay, let's see what it is. Correct. Rebreathing, because you can see the pattern, it drops down and not to the baseline though, and then goes up. What about C? What's happening with C? ROSC, yes. C is probably ROSC. Even rebreathing it says, but you can see similar thing in the ROSC with a low amplitude. The only thing that represents rebreathing is it not touching the baseline. The fourth one is pregnancy, where you get a upstroke because of functional residual volume is low, so you'll get a upstroke in the pregnancy. E is the curare cleft, where patient starts to come back from the muscle relaxation. F is rebreathing again. As you can see, it is not coming to the baseline. Esophageal intubation, like you'll have some sort of CO2 to start with, but as with subsequent breath, it will drop down to 0. H is spontaneous breathing. You can see they're trying to breathe spontaneously, not with the greater amplitude, but it's similar to spontaneous breathing like that. I'm not sure where did they get a lung transplant here. Forget about that. I cannot explain that EtCO2 from this graphic. Malignant hyperpyrexia, just based on the number, where you have a higher EtCO2, malignant hyperpyrexia can be, or fever can cause these things, or hypermetabolic syndrome. Cardiogenic oscillation, you can get these oscillations transferred with the air going out. With each cardiac contraction, you will get some sort of exhalation, so that is suggestive of that. This is sensor contamination, where there is gradual increase in CO2 level. So the baseline also gradually increases. So you can see this in sensor contamination. M is spontaneous breathing with intermittent ventilation. So the square pattern here is the mandatory breath, followed by these two are the spontaneous ventilation. CPR, as you can see, low volume, irregular. Yep, so that's CPR. And the last one is again rebreathing or spontaneous ventilation. You can see these are the mandatory breaths probably, but again it is not coming to the baseline, so it may be associated with some rebreathing. So these are the few abnormalities that can be asked in the exam, but the most common that will be asked is a curare cleft usually, or esophageal intubation, or a CPR, or a bronchospasm with sarcopenia. So these are the 4 and 5 common things that are asked in the exam. Arterial waveform. Now usually the arterial or invasive arterial waveform has two parts, an anacrotic limb and a dicrotic limb, and you'll have a systolic peak with a dicrotic notch. The area under this whole waveform or one waveform represents your mean arterial pressure. If the area is high, you have a high mean arterial pressure. If your area is low, you have a low mean arterial pressure. Now, with the same systolic, you can have a different mean arterial pressure. As you can see, this area is almost half of this area. In this case, the mean arterial pressure is higher compared to here, which is a very skinny wave. The mean arterial pressure is low. So based on same systolic and diastolic, you can have a different mean arterial pressure on this one. Okay. Now, based on where you are measuring, there will be different types of waveform. Again, this can be framed as a question showing you locate the site of the arterial line. So aortic, usually aortic cannulation, you can have this sort of waveform where you have big elastic vessels and the trace is slurred because it is damp. Brachial artery, again the dicrotic notch is bit higher. As you go down and down, the notch gradually comes down and it slips down the ridge there. So with the dorsalis pedis, you can see the dicrotic notch is much lower than where it is in the brachial artery or in the aorta. Okay, so based on where the dicrotic notch is, you can say where the arterial waveform is coming from. Again, the same representation, that's the aortic waveform compared to this is a dorsalis pedis waveform where the dicrotic notch is much lower. Similar thing happen in also in sepsis, where you will have your dicrotic notch much lower, and that also is an indirect representation of vasodilatation in some patients with sepsis and septic shock or a vasodilatory shock. Now they are very fond of asking what type of waveform is this. This is a normal waveform, this is overdamp, this is underdamp. The difference is in overdamp, you will not have a very big waveform. In underdamp, you will have a very high peak and a very low diastolic pressure. Now, how to differentiate that? We do a flush test or fast flush test that we do. We open the transducer to the maximum pressure and let the and then release it to see where the pressure or how many waveforms are required for the pressure waveform to come to the baseline reading. Okay, in this case, this is the over damped waveform where the diacritic notch is lost, and if you do a fast flush test, it comes back to the usual waveform within one sort of oscillation, which represents a overdamped waveform. It can also happen if there is an air bubble in the tubing, if there is a clot in the catheter or kinks in the catheter, if the connections are loose or the artery has gone into spasm. So all these things can cause a overdamped waveform. Similarly, the underdamped waveform, you can see multiple artifacts because of the high resonance of the whole system. And if you do a flush test, it will take more than 2 oscillations for the system to come to baseline here. But both with the overdamp or underdamp, your mean arterial pressure will remain the same or almost the same, not always the same number, but it will be almost the same. With a with an underdamped waveform, we will have a systolic blood pressure which is overestimated, as you can see there, and a diastolic blood pressure which is underestimated. So this one will be high, this one will be low than normal. Okay, so that's the characteristics of the underdamped waveform. It can also happen if you have a stiff tubing, if your stopcocks are there are multiple stopcock, and patient factors such as the patient has a high cardiac output, is having hypothermia, or is tachycardic. All these things can also present as a underdamped waveform. So optimally damp, you get back to your parent waveform within 2.5 or 1 or 2 oscillation. Under damp, you take forever to come back, and over damp, if it is, then it will not allow more than 1 oscillation to come back to the baseline. So that's how you test the damping of the arterial line. Again, there are various type of pulses that you can encounter in arterial line apart from the damping. They can ask you what sort of waveform is this. So this is a pulses alternance, which you can have a high amplitude and a low amplitude alternatively. This can happen predominantly in a left ventricular failure or patients with arrhythmias. Most common cause is a left ventricular failure. You can have pulsus bisferens, where you have 2 systolic peaks in one waveform. This can happen in aortic regurgitation, but more commonly in a hypertrophic cardiomyopathy. That's where you'll find. Pulsus paradoxus, very common in clinical findings. So pulsus paradoxus is a paradoxical name itself. What happens is, with spontaneous ventilation, your systolic blood pressure goes down by more than 10 millimeter of mercury. Usually it is less than 10, but in pulsus paradoxus, this drop in systolic blood pressure is more exaggerated. So this happens in cardiac tamponade, constrictive pericarditis, COPD, hypovolemic shock, severe asthma, and pulmonary embolus. So any of these causes which can cause a significant pressure change in intrathoracic cavity can cause a pulsus paradoxus. Reverse pulsus paradoxus, which happens reverse, so you will have an increase in blood pressure by more than 10 during positive pressure ventilation. This is more common in a hypovolemic patient. If you have a reverse pulsus paradoxus, think of a patient who will require fluid. Something called as a pulsus parvus, where the pulse pressure is reduced. As you can see, 100 by 80. So the pulse pressure is reduced, commonly seen in aortic stenosis or left ventricular failure, also in shock, but most commonly in aortic stenosis you will have a low pulse pressure, pulsus parvus. So you need to know at least pulsus paradoxus and what do you mean by pulsus alternans. So these are the 2 things they may be asking in the exam with some waveform showing pictures. The third thing that we'll talk about, IABP. This is again a very there are not many abnormality in IABP. You'll get 4 or 5 predominant abnormality in IABP that can be asked. You can given a You will be given a picture to show to identify the rhythm and what is the abnormality, what is that. But there may be associated questions to that. They will be asking about what are the indications of using IABP, what is the evidence behind it, what are the trials that you know, what are the contraindications for IABP, and what can be the complications associated with it. So first of all, one abnormal waveform, and they will be asking about other associated questions. So what are the indications of IABP? Usually it is a bridging treatment, bridging to surgery or bridging to recovery. In ischemic heart disease where the cardiac output is low, you want to augment the coronary perfusion. Evidence behind it, so not much evidence for improving outcome except for the field of bridging to a surgery. We cannot, based on the current evidence, you cannot treat a cardiomyopathy patient with only IABP where there is no reversibility, because it will not change the outcome. Contraindication, there are multiple. You have to classify the contraindication, whether the patient has some aortic valve disease, whether the patient is coagulopathic, whether there is peripheral vascular disease, etc. So there are multiple layers of contraindication that can be asked in this exam. So you have to talk about contraindication about patient or patient's baseline clinical condition. Those things have to consider. Complication, again, you have to divide the complication: machine related, patient related, and so machine related can be like balloon embolism, air embolism due to balloon, or ischemic leg due to the size of the balloon. In patient related, it can be starting from infection, bleeding, again ischemia, mesenteric ischemia because of occlusion of the mesenteric arteries, renal failure because of occlusion of the renal arteries, perforation, etc. So that they can ask any of these questions associated with a IABP waveform. So let's talk about the different abnormalities of the IABP waveform. So first of all, this is a normal IABP waveform where you can see the arterial waveform, this one, and this is augmented IABP waveform. The peaks here, so the IABP starts inflating at the diacritic notch, and this waveform is called as the diastolic augmentation pressure. This is the diastolic augmentation pressure. So this is what we are looking at, because during the diastole only the coronary arteries gets perfused. So if we push the blood pressure higher during the diastole, then it will improve the coronary perfusion. All right. It also reduces the afterload to the heart. So these are the two major mechanisms how the IBP works. One is increasing coronary perfusion, thereby in improving oxygen supply to the coronary muscles. Number two is to reduce the afterload, thereby reducing the oxygen demand also. Okay. So that's the usual IABP form. What things can go wrong? Now, again, little bit of physiology. So as I said, usually the balloon gets inflated at the diacritic notch, which corresponds to the middle of the T wave, as you can see if you plot the ECG, and the deflation happens at the middle of the QRS complex. That should be the ideal inflation and deflation phase. If something happens before or after, or deflation happens before or after, that's where the pathology arises. So it can be early inflation or late inflation, early deflation or late deflation, based on where the depletion is happening correspond to the ECG. Right, so there may be 5 abnormalities that can happen at IABP. One is the early balloon inflation, late balloon inflation, early balloon deflation, late balloon deflation, and the last one is poor diastolic augmentation due to suboptimal coronary perfusion or not adequate inflation of the balloon. The balloon is not inflating fully, rather than 20, 30 or 40%, right? So these are the 5 abnormalities that is seen with balloon. Now early inflation, as you can see, it should inflate at the diacritic notch, but it has inflated much higher up here. So this is an early inflation. So what can happen with early inflation is increased left ventricular oxygen demand due to increased afterload. So if it inflates early in the systole, Then the heart has to push blood against an inflated balloon inside the aorta. So that means you need more work to be done. Your afterload has increased. That leads to decreased left ventricular oxygen supply because you're not getting much forward flow due to decreased diastolic perfusion, also because you are not able to augment enough. And there is decreased cardiac output due to decreased stroke volume because there is an obstruction already there in the aortic lumen because it has inflated during the systole. Okay, so that's the consequence of early inflation. Now late inflation, it should have inflated here, but it has inflated much afterwards. So what can happen with it is there will be decreased diastolic augmentation. The augmentation should happen with this waveform, this much high, so that the coronaries are well perfused in the diastole. But because it is lately inflating, the augmentation is much lower, and thereby the coronary perfusion will be compromised. So it will not serve the purpose. Early deflation. So the deflation should happen much later, somewhere there, right? It should happen there, but it has happened much earlier. So what will it cause? It will cause there is failure of improvement of left ventricular afterload, fails to decrease left ventricular oxygen demand. Because it is deflating early, it is not assisting much time for the diastolic flow to the coronaries. It also fails to decrease myocardial oxygen demand and does not help in any reduction of the afterload because it is deflating very early, right? So the late deflation, or sorry, early deflation can lead to decreased oxygen, failure to decrease the oxygen demand, like still you need much more work done by the cardiac muscles because there is no decrease in afterload, and also there is suboptimal augmentation of the diastolic flow to the coronary arteries. Similarly, late deflation, which is not preferable because it is getting open for a long time, and what it will cause is the aortic end diastolic pressure does not have enough time to decrease by the time the LV is ready to contract again. So late balloon deflation increases the aortic end diastolic pressure. This is higher, increased in aortic end diastolic pressure, and thus increases the afterload and left ventricular oxygen consumption. So anything that increases the afterload will cause increase in the left ventricular oxygen consumption. Instead of the diastolic pressure being here, it is risen up there. So there will be more oxygen consumption by the cardiac muscles. Doesn't work. Poor augmentation, again the whole of the balloon is not inflating, not 100% augmenting. The actual diastolic augmentation should be here somewhere, but it is much less, so it will not be able to serve the purpose of perfusing the coronary arteries. So that's more or less 5 abnormalities that can be asked in the exam. You need to practice these waveforms. But as I said, there will be another part to the question regarding indication, contraindication, complication, and trials about it. Okay, we talked about that already. Pulmonary artery catheter, again, this is depends on which center you are facing the exam. If you are facing facing the exam in a cardiothoracic center who are pro using the pulmonary artery catheter, then this will be there for the Viva for sure. Okay. Now, what the major thing to know is the different types of waveform that is there in the monitor, or you see in the monitor while putting pulmonary artery catheter. So while you float the pulmonary artery catheter, or initially you put the catheter inside, as you can see, into the RA, and then let the balloon inflate so that it goes through the valve along the flow of the blood into the right ventricle and then into the PA. All right. So initially, the pressure that you see in the right atrium is a usual CVP waveform with a C, V, A, Y, and X components to that. So usual CVP waveform, as you can see. But when it reaches, as you can see, the balloon reaches the RV, that's where you will get a systolic and a diastolic pressure. The RV waveform is a systolic of somewhere between 15 to, if it is normal, to 30, somewhere there. But the most important thing is to note is the diastolic is 0. So diastolic pressure in RV is 0. That's the hallmark of saying that the catheter is in the RV. Then the catheter turns and goes through the PA. Once it reaches the PA, then we'll get the pulmonary artery pressure, which will be just like a usual systemic artery pressure, like a systolic and a diastolic blood pressure with a diacritic notch, but the numbers are low. So it will be same as the RV, like whatever 15, 20, 25, but you'll get a diastolic which is around 8 to 10 there, right? It's not 0. If it becomes 0, then you are in the RV. If it becomes a higher number, then it is in the PA. Now still continue pushing the catheter so that it gets engaged into a for the smaller artery where you can inflate the balloon and occlude, so that you will not measure the pressure on the back side here. You will measure the pressure on the front side, or the left atrial pressure that you can gauge from here, or pulmonary artery wedge pressure. So what do we say? At this point, when the balloon occludes the lumen of the smaller pulmonary artery, then it will give us a pressure distal to this part, which is the wedge pressure, or the balloon is wedging there and you are measuring the pressure which is more proximal, which can be the left atrial pressure or pulmonary artery wedge pressure. So that will be again looking like a CVP waveform, but the number will be much higher, as you can see here. Okay, so initially CVP waveform, right atrium, blood pressure like pressure which is like 20 by 0 or 25 by 0 RV, the catheter in the RV. Then it goes into the pulmonary artery or main PA, where you'll have a pressure of 25 by 8 or 15 by 7 or something like that. That will be the PA pressures. And then you go down further wedging. In the wedging, you will get again a slightly higher value, but the waveform will look like a CVP or smaller amplitude CVP waveform. So that's the usual course of a pulmonary artery catheter. Now again, the question, half of the question will be about identify the waveform where the catheter tip is. They can show you an X-ray to see the PA catheter waveform, or PA catheter, how does it look like in the X-ray. And the further question, what are the uses like thermodilation, measuring pressure, titrating inotropes, titrating pulmonary vasodilator. These are the uses of a pulmonary artery catheter. They can ask you about the complications while putting it. They can ask you about studies that have uh, shown, or recent studies, or landmark studies that has shown that pulmonary artery catheter does not improve the outcome of the patient, but why do you use in the clinical setting? To get more information so that those information can be translated in managing the patient. As such, it is not an intervention to improve the outcome, but rather it is a device that gives you the value to act on. Similarly, like talking about why do you put an art line? The art line will not improve the outcome, but the information that you get from an art line, you use it to treat someone, similar to PA catheter. So you need to know about the evidence around it. Okay. CVP waveform again. I've seen many advanced trainee, they have no idea how the CVP waveform should look and what are the components of it, even they don't know much of the other things, but they neglect the CVP waveform in the exam, and these are the things that often the candidates get caught up with. Okay, usually the CVP waveform has AC and V as the positive wave and X and Y as the negative wave. And each of these waves corresponds to something. A corresponds to the atrial contraction, C corresponds to the phenomena of tricuspid valve, elevation into the right atrium. Then X corresponds to downward movement of the contracting right ventricle. V represents the back pressure wave from blood filling from the right atrium. And Y descent again is tricuspid valve opens in early ventricular diastole. So X and Y are the descent and ACV are the positive waves. Now, abnormalities that can be asked in the exam is loss of A wave where you don't have atrial contraction. Canon A waves where you will have very high peaked A waves. Now this one, you can get a Canon A wave in junctional rhythm and other pathology, as you can see, where the right atrium contracts against a closed tricuspid valve. So as you can see, the A wave is like tall ones, where there is junctional rhythm. You can't see the P waves there. Can you see here? You can't see the P waves here. So you will have a junctional rhythm where the right atrium is contracting against a closed tricuspid valve, thereby increasing the pressure inside the right atrium, causing a high pressure representation or canon A waves. But as the pulse becomes more sinus, you can see the P waves here. The canon A waves disappear with only positive A waves, smaller A waves, as you can see here, right? So this is a very good picture of junctional rhythm and sinus rhythm, canon A waves in the junctional rhythm, and no canon A waves or normal A waves in the sinus rhythm. Similar picture here, same thing. Tricuspid regurgitation, what do you find? You find the fusion of the C and V wave. We call it as a CV wave. Okay, we call it CV wave in tricuspid regurgitation. Memorize this figure. Cardiac tamponade. So this is a normal CEP. In cardiac tamponade, you will lose the Y descent. You can see only Y, only X descent, only X, only X. You will lose the Y descent. But in constrictive pericarditis, you will have steep abrupt X and Y descent. So you can see the X descent and the Y descent become very steep in constrictive pericarditis compared to cardiac tamponade where you will not have the Y descent. In the exam, they are very fond of asking about C and V wave fusion and X descent, Y descent absent in constrictive in cardiac tamponade, and both X and Y becomes deep in constrictive pericarditis. These are the three things they usually ask, and also the canon A waves. Going to the next topic, ICP monitoring waveform. Again, this is a very important thing that you need to know. Usual ICP waveform has three waveforms. We call it as P1, P2, and P3. P1 represents the percussion wave, which is the pulsation coming from the choroidal plexus pulsation. It represents the systolic peak in the arterial line. P2 is the tidal wave, and P3 is the dichrotic wave. Now P1, as I said, the percussion wave. P2 tidal represents the intracranial compliance. So P2 is a waveform that is because of the return of the arterial waveform, and it is an indirect what do you call marker of the intracranial compliance. Dichrotic notch represents the venous pulsation. In normal ICP waveform, P1 is usually greater than the P2, and P2 is also greater than P3. So P1, P2, P3 lie according to their height. Like P1 is highest, P2 is middle, and P3 is there. And if you look at the monitor in general, eyeballing it, you can tell what is happening. As you can see on the right side, the red one is the arterial waveform and the white one is the ICP waveform. They are being overlapped. As you can see, P1 overlaps with the with the systolic peak. P2 is the tidal wave, and P3 is the dichrotic wave. In raised ICP, what happens is, because of increasing intracranial compliance, the P2 waveform becomes bigger than the P1. That is a sign of increasing intracranial pressure. So these are the four abnormalities shown in this picture. The first one is the normal ICP. Second one is severe arterial hypertension and hyperventilation. In both cases, you'll have the P2 and P1 almost in the same height, and gradually the P2 will go up and up. Okay, as you can see in this third picture, the P2 has gone up and or higher than the P1, representing a rapidly expanding mass lesion which can cause a raised intracranial pressure. The last one, you can see where the skull is decompressed and there is no skull above the brain, and you have a monitor there. In those cases, you will get a undulating type of waveform. If you put your hand onto the scalp, pretending your hand to be the skull or the cranium that has been taken off, then you will start to get these type of waveforms. So basically, in this intracranial waveform, they usually ask about the names of these one and what are the pathology that you expect if the P2 is greater than P1. That is loss of intracranial compliance or raised ICP. Now there is something called as the Lundberg wave that you can see. This is we were talking about earlier. So this one is only one waveform, but if you let the waveform to be multiple waveforms over time, then you can have three patterns. We call it as a Lundberg A wave, B wave, and C wave pattern. A wave is always pathological. Here you'll have a high amplitude and the pressure is around 50. This is supraphysiological pressure, suggestive of low brain compliance. This is abnormal. B pattern, where you will have rhythmic oscillation, amplitude is less than 50 millimeter of mercury, and it occurs every 1 to 2 minutes, seen in patients undergoing mechanical ventilation. It doesn't have much of a clinical significance, but you can see these changes in a mechanically ventilated patient. And the C pattern, where you have rhythmic oscillation, amplitude is less than 20, and this happens every 4 to 8 minutes. This is non-pathological. This is the normal pattern that you see. If you see a pattern, then it is pathological. C is normal. B, we don't know the significance of it. But usually in our clinical monitoring, we don't monitor waveforms with this. This is all theoretical that has been seen in different experiments. In clinical sense, we see a single waveform like this or this one. If you squeeze it, like if you, what do you say, decrease the frame rate, getting hundreds of waveform in one screen, then you can get this pattern like this, the way it is, right? So these are all singular waveform over time and the variation over time. Okay, if it varies every 5 minutes or 4 minutes and that peak doesn't go beyond 20, this is normal. Here there is no variation and the peak stays as 50. This is very abnormal. These waveform pattern are called as Lundberg waves. All right. Now I talked to you about mechanical ventilation or ventilatory waveform. I don't want to take a class on this because this is very exhaustive to sit and get through the ventilator waveform, but I'll give you a pattern how and what are the things that is asked in the exam. In common, it is called as a patient ventilator asynchrony waveform, which can be due to phase asynchrony or which can be due to flow asynchrony. Don't bother about that. Just look at what are the things that is asked in the exam. So one pattern is reverse triggering. Have a look. What do you mean by reverse triggering? What is the mechanism causing it? How do you get rid of reverse triggering? So trigger abnormality. There can be three trigger abnormality. One is called as reverse triggering. One is called as double triggering. The third one is called as ineffective triggering and auto triggering. Okay, there are four different abnormalities that can happen due to trigger problem: reverse, double, ineffective, and auto triggering. Auto triggering happens because of patient movement or even the heart movement can cause auto triggering. Ineffective triggering, patient coming out of the anesthesia or a paralysis, not effectively triggering the set trigger, whether it is a flow or whether it is a pressure trigger. Ineffectivity triggering can happen with that. Double triggering, again, this can be restless patient coming out of the paralysis, etc. That can happen similar to the reverse triggering also. So you need to look at the pattern, the waveform, how it looks like. Okay, so there are the four abnormalities in trigger that may be asked in the exam. You need to know what causes it, how do you get rid of it. So, then next is cycling. Again, there are two types of cycling abnormality: premature cycling and late cycling. Why it happens and how do you treat it? So premature cycling, again, your eye ratio may be altered. Similarly, late cycling, your inspiratory time is too high. Um, so how to correct it? Changing the flow or moderating the flow can change it based on what type of ventilation the patient is on. Have a look at these two abnormal waveform. Okay, they usually ask this. Then flow in asynchrony, it can be insufficient flow and excessive flow. Again, you will have those scoopings in the flow pattern, which says that the flow is not adequate for the patient. Excessive flow again will have present with a high pressures in the ventilator graphics. But these are the 8 or 9 abnormalities that is usually asked in the exam with a picture or a running video. Make sure that you practice this before going to the exam. Apart from this, there will be no other questions in respiratory. mechanics or respiratory waveform. Each of them is important. You need to identify, first of all, what causes it and how do you take care of it. These are the three things they will be asking. The few other things that can be asked in ventilator or respiratory waveform is auto peep. You guys are master in auto peep, I believe, how to look at it and how to treat it. But that is another very commonly asked, how to treat auto peep and how do you identify auto peep. So I'm not going into detail because that will take another half an hour. I don't want to chew up time from the other presenter, but this will be all discussed in detail in our upcoming course or the crash course that we plan for. So you are welcome to join that to have more details about it. But these are the basic structure of questions in waveform that is asked.